All right, good morning, everyone. And I'm Cindy Bombard. I'm President and CEO of the Central Connecticut Chambers of Commerce. We're based out of Bristol, but we manage about 1,600 members, 6 chambers of commerces, and we are very fortunate to have 2 manufacturing associations underneath the umbrella here at the chamber office. And we're very proud of what we do. And I really want to give kudos to Lisa Roy, who's one of our board members from Jack's Labs, to help coordinate this event this morning. Because without people like Lisa on our board, and we have 27 board members, I don't have all of the contacts to put programs on like this. So we really appreciate, Lisa, your time and effort to doing this, and for all of our speakers, which Paul will introduce in just a moment. I also want to thank Connecticut, who is our sponsor, is a very good chamber partner with us. And Robert, I would like you to say a few words on behalf of Connecticut, but I want to give you a briefing of what Robert does for Connecticut. He is the Senior Vice President of Pharmacy and Medical Cost Management at Connecticut and in Emblem Health. And he's got more than 25 years of experience in finance and operation management. He's a certified public accountant, and he's earned his bachelor's degree in business administration and accounting from the University of Connecticut and completed Wharton's executive development program at the University of Pennsylvania. So I really want to thank you, Robert, for giving us your time this morning and all the help from Kim Kahn and her team. So Robert, a little briefing from Connecticut.
Thank you, Cindy. It's a pleasure to be with you this morning. You know, the COVID pandemic has changed our world. Locally, globally, people of all ages, all countries have been affected. We've changed how we work, how we live, how we interact personally and professionally. We wear masks now to protect others and to protect ourselves. And as the pandemic first appeared in our state, Connecticut quickly adopted so that we can continue to serve our customers. We moved our employees to work from home. We made changes to coverage, including expanding telehealth services for our members, increasing prescription drug refills to cover 90-day supplies. We reduced administrative requirements for our providers and much more. But what I'm most proud of is a program that we put in place called Peace of Mind. In our Peace of Mind program, our nurses, our social workers, and our service team members call tens of thousands of our members at the highest risk for contracting COVID-19 to simply check on them. The question we ask is, how are you doing? We weren't calling to tell them that they are behind on preventive services or ask them to do anything. We asked a simple question and we listened. We helped with lots of things related to their health insurance and things completely unrelated to insurance. We learned that people are scared and stressed and anxious about many things. We helped with setting up telehealth visits, having prescriptions delivered to their homes, connecting to community resources for food. Most people were surprised by the call, but they also appreciated that we took the time to call and just talk to them. It's been a hard year, and as we see the number of cases rising, we wonder what the future will hold. I can assure you that Connecticut, as Connecticut's health plan, will be here providing high-quality health plans, just as we have done for 40 years. Today's program will look ahead and discuss what we can expect in 2021 in Connecticut regarding COVID-19, from our preparedness to testing, diagnosis, treatment, and vaccines. Connecticut is sponsoring today's important discussion because it aligns with our mission to create healthier futures for our customers and our communities. Thank you for attending. I'm sure that we will all learn something today. Back to you, Cindy. Thank you.
Thank you, Robert. Thank you again for Connecticut's support. We really appreciate it. And I want to remind everybody, please use the chat. Katie's going to be monitoring the chat box to answer any questions as we move along. So we could, address everybody's questions during and at the end. So I'm going to turn it over to Paul Lavoie. Paul Lavoie is the chair of our board here at Central Connecticut Chambers of Commerce, who's going to be moderating this morning's talk. Thanks again. Paul, you're
Good
on.
morning. Thank you, Cindy. And welcome to everybody, and thank you for participating in our forum today. The Central Connecticut Chambers of Commerce is committed to providing our members and the general public with important and timely information. As we all know, we're in the midst of a public health crisis, and the coronavirus will be with us for a while. While it may be difficult to eliminate this virus, our research and medical professionals have made significant progress on containing the spread and the treatment of this virus. Today, we've put together a panel of industry experts in research, testing, pharmaceutical development, and the prevention of this virus. Our panelists will provide us with updates on changes in testing, diagnostic and testing, as well as updates on the introduction of successful vaccines. For a little perspective, I'd like to share the timeline of COVID-19 in Connecticut. Our first case was reported on March 8th. On March 10th, a public health emergency was announced. We closed our schools on March 16th. We recorded our first death on March 18th. On March 20th, non-essential businesses closed. March 23rd, a stay-at-home order was issued. And on April 3rd, the reproduction number drops below 1. This is the number of people an infected person will pass the disease to, less than 1 in April. So in May, we went to phase 1 of reopening. June 17th, the governor went to phase 2 of reopening. July 20th, we went to phase 3 of reopening. And on November 6th, due to increasing cases, we rolled back to phase 2.1 with additional restrictions. And that brings us to today. So please join me today in welcoming our 3 distinguished panelists for our discussion. We are joined by Mark Adams, Deputy Director, Professor and Director of Clinical Diagnostic Research for the Jackson Laboratory, Dr. David Bannock, Head of Infection Prevention and Hospital Epidemiologist at UConn Health, and Morelli Fino, Site Head of Industrial Operations at Protein Sciences. Welcome to our panelists. We'd like each one of you to please introduce yourself to our audience, introduce your organization and your role within the company. We'll start with Mr. Adams. Good morning, Mark.
Good morning. Thanks to everyone for being here to hear about the updates on this topic that I think we're all very, very interested in from a variety of personal and professional perspectives. As Paul mentioned, really things got off to a very aggressive start in the state in March, and Jax was part of that in terms of developing the testing program. Beginning early in March, we worked closely with the State Department of Health to add a virology testing component to our CLIA lab certification, which at the time we didn't have. And that began a process that is still continuing to this day of trying to expand the capacity to perform assays here, where we've continually tried to invest in making more robust processes and increase our capacity while still maintaining a turnaround time, ideally, of around 24 hours for return of results. As I think everyone knows now, the best way to reduce the spread of the coronavirus is to reduce contacts. But of course, that's not possible for everyone in every context. And so being able to recognize symptoms and get tested, being able to know that you've been in contact with someone else who has tested positive, and in turn determine your own status is really important for recognizing and limiting the spread. And the testing program then has been really key to that. One important part, although it's certainly not the only part of that. And it's been a real pleasure for Jax to work with partners through the state, through the National Guard, through Griffin Hospital and Hartford Healthcare and other organizations that we work with to serve hospitals, nursing homes, colleges and universities, first responders, to get these timely results out. And with that by way of introduction, I'll pass along and we can get back to further information on testing as part of the questions.
Thank you. And I will let everybody know, we do have some questions prepared for our panelists, and we will be accepting questions from you as well. So as Cindy said, please use the chat box. So Dr. Bannock, please introduce yourself.
So thank you for the invitation to come and speak. My name is David Bannock. I'm a physician with infectious disease training. In that role, I see patients in the hospital, take care of patients with different infections, including COVID-19. My other role is in a role of prevention. So I'm the medical director for our infection prevention program here at UConn Health. And in that role, I work with our staff and all of our collaborators in order to focus our efforts on preventing the spread of infections, both to our healthcare workers and also preventing infections in our patients. So through the COVID pandemic, a lot of my roles have been focused on the development of policies and protocols for things like personal protective equipment, coordinating our contact tracing for our employees, just as Dr. Adams alluded to. And a lot of that relates to coordinating testing for our institution. There's other aspects of clinical care, such as bringing on new therapeutics for our patients, which has been, kind of an exciting aspect of COVID-19. And, I think as this subsequent wave approaches us, we have a lot of a lot of challenges. The approach is a little bit different than our approach in the spring. I'd be happy to talk to that in some more detail. But I think we are working hard. We're enthused about some of the opportunities that may lie ahead, including new therapies and vaccination. And I think we're taking it one step at a time, but working hard, and I'm happy to talk about some more details of what we're doing here in the hospital to help meet the needs of our patients and our community.
Great, thank you very much. And now, Ms. Fino Morelli, good morning.
Yes, good morning. Thank you for having me. It's a pleasure to be here. I'm as the site head of operations for Protein Sciences. Very early from the pandemic, it was very clear that we would be working on a vaccine for COVID. We had work with BARDA, with the government of the United States, in the development of the influenza vaccine. Protein Science brought to the market the first recombinant influenza vaccine. And because the platform, it can be used for many different diseases, we were approached very early in January and February to start working on the vaccine. My experience is in vaccine for the last 25 years. I work for very large companies like Pfizer and Wyeth. In Protein Sciences, we, in addition of launching the flu vaccine, the recombinant vaccine, we work in many other vaccines like Zika, Ebola, etc. And we knew that we're going to have to compress the timeline, right? So one of the most important things was for us, how do we look at the full spectrum of what needs to be done to bring a vaccine from development all the way to distribution, as part of the Sanofi umbrella, working with all our groups and with the collaboration on and the selection of the adjuvant with GSK. So it has been quite a year for us. In addition of making sure that we provide a safe environment for our employees, because they had to come back, they had to continue working. We had to double down on our efforts to deliver a higher demand of the flu vaccine, at the same time that focusing on that development, clinical production, going to the clinic, etc. So has been very, very interesting, very energizing at the same time. The time has gone unbelievably fast. But the best part of it is that we have seen from the beginning, from the preclinical data in the animal models and the phase 1 vaccines, very, very good data and very encouraging data. So it has been a race, but very interesting and in general, getting very positive results. So very much looking forward to it.
Great, thank you very much. So our first question today is directed to Mark Adams from the Jackson Laboratory. Mark, as you mentioned, Jackson Laboratory has been on the forefront and an early partner with the state of Connecticut on testing. Can you give us just an overview of how testing has evolved over the past 8 months? And what are some of the newest developments that we can expect in 2021?
Sure. So on the one hand, we're running exactly the same tests that we were running back in March. And so on the one hand, I think that stability from a manufacturing supply chain perspective has been a positive, a success story of overall testing. So we're using an assay from Thermo Fisher that uses quantitative PCR for determining the viral load in a sample. And that is really the gold standard of testing in terms of both sensitivity and specificity. We're currently running somewhere around a quarter to a third of all the tests that are performed for the state of Connecticut. And frankly, in the summer, I had expected that we would be shifting at some point to more rapid point of care tests that could be run within nursing homes with results that are available within 10 to 15 minutes. That's now starting through the Abbott Binax Now test and some others that will be coming on the market. But the availability of those is still quite limited. And the sensitivity of those assays is also not as high as you'd really like. And so there's sort of a narrow window of capturing a person who is infectious in terms of the ability of that test to recognize someone who is in fact infected. So that has meant that the demand for the more sensitive qPCR tests has been maintained and in fact has even grown. And I think as we go through the winter, for a variety of individuals and testing scenarios, this is going to continue to be the preferred assay that's run because of that sensitivity and the ability to detect an infection even sooner. So the rapid tests are based on an antigen, which is the actual presence of the viral protein or viral particles in a sample. And that requires much more sample volume because the assay isn't quite as sensitive. Whereas the qPCR tests depend on the nucleic acid, which can be either from the virus itself or from an infected cell that comes along with an anterior nary swab or saliva sample or what have you. That broader range of tests is what makes it more sensitive. There's also an antibody test that folks may have heard of. This tests the presence of antibodies to the virus in your bloodstream. And these tests are also available and they're marketed. It's important to know, though, that they can only give information about past infection, not in current infection status. And so there was a study done sponsored by the state, led by Yale, Gallup, and Quest that Jax also participated in to evaluate what percentage of people in the state had a positive antibody result as of July. And so Gallup, when they weren't doing other polling activities, put their expertise to good use to get a random sample of Connecticut folks to come in and give a blood sample at Quest. And what was found in that study was only about 5% of people had been exposed to coronavirus. So might have been infected without knowing it, for example. And what that means is that a vast majority of Connecticut citizens came into the fall susceptible to the virus. And I think we're seeing part of the result of that now. In terms of other aspects of the evolution, I think what has really solidified and helped a lot is these relationships between the groups at UConn, at Hartford Hospital, at Griffin, at Yale, at other sites managed by the state that are coordinating the sample testing sites. And there's still, I think at this point, a lot of interest in expanding that access to testing. I've seen the news that that's a real limitation in terms of slots available for people getting the sampling. And then all of the groups, Jax and others that are doing the assays for determining the viral load are also still struggling and mostly succeeding to expand capacity. So I'll stop there and we'll leave it to questions going forward, follow up.
Great, thank you very much. Next question's for Dr. Banik. Dr. Banik, with infections and hospitalizations on the rise, and as we enter into flu season, there have been concerns of multiplexing, which is the contracting of the coronavirus in conjunction with the flu, a possible twindemic, if you will. What are you seeing so far at UConn Health, and what lessons have hospitals learned to prepare to handle the influx of cases that we'll continue to see?
So I think, with regard to the first question, the impact of influenza on what we anticipate to see, I think, we have some mixed feelings about that. We know that every year the flu contributes to a large number of patients being hospitalized, and that is something that we do need to prepare for. We have flu testing capabilities. In fact, a lot of the flu testing uses the same type of that PCR technology that Dr. Adams had alluded to earlier with the testing for coronavirus. And flu testing is something that we have become very familiar with using these types of platforms. So we do have the testing capabilities. And I think, the question comes into play is really what to expect. We know that this is the time that we start to see flu cases, and there's a lot of variation with that. In some seasons, we don't see flu appear until much later in the winter, around February, March. Interestingly, a lot of the measures that we're taking to prevent the spread of COVID-19 also prevent the spread of the flu. So things like masking when in indoor contact and trying to avoid group gatherings. School children are really thought to be a predominant reservoir for flu infections. And now with schools being kind of dialed back in a lot of ways in terms of in-person learning, that may actually portend a milder flu season. I think that's been seen in other areas of the world, like for instance, in the Southern Hemisphere, during our summer months and their winter months, they saw a very mild flu season. So I think there's some optimism that we may not necessarily see as a severe flu season because we have these measures, these preventive measures already in place. That being said, we have to focus on these measures, plus all of our other flu prevention measures, notably the flu vaccine. And that's something that we've really been encouraging for our patients and our employees, really pushing to try to do as much as we can to protect against the flu. Because if we do see that, what's been termed a twindemic, sort of the COVID pandemic and also the flu pandemic, or the flu, the seasonal flu, occurring simultaneously, that will put some pressure on our hospital systems, which are already under, pretty significant pressure. So, transitioning to the question you asked about, what we're thinking about now from the hospital perspective compared to what happened in the spring. I think, things do look a lot different right now. We're seeing high rates of COVID in the community. We're admitting increasing numbers of patients with COVID-19 to our hospital. In fact, over the past for 2 weeks, there's been a substantial increase in our number of hospital admissions here at UConn and across the state for patients with COVID-19. So, we are seeing increases. When we think back to the spring, the layout was a little bit different. We had, in accordance with public health recommendations, stopped doing elective surgeries. And our hospital volumes were down, also potentially attributed to fear amongst individuals in the community who are afraid to come to hospitals, concerned about their safety, knowing that we were seeing lots of COVID-19 patients. So for instance, our ED volume actually went down in the spring overall, but certainly was dominated by COVID-19 patients. So now we're seeing a different picture. We're seeing COVID-19 patients coming in, but also patients with the typical emergencies that we commonly see. People coming in with heart attacks, with strokes, with trauma injuries, and we're still doing surgeries. I think our surgical volume may not be quite where it typically is at this time of year, but it is still quite high. We're approaching that level. So, we're developing plans where we're able to provide safe and high quality care to all of our patients who come in with COVID, but also those without COVID. And our hospital volume overall is quite high. So I think that is our approach, and I think we're still have the same measures in place to protect our patients and our staff. But it feels like it's a big undertaking for hospitals at this point to be able to provide care for all of our patients, including those with COVID-19. And I think the other challenge that hospitals are up against is that with high rates of COVID-19 in the community, we have a lot of staff that are becoming infected in the community, just like any other individual in the state, working in any other industry. I think fortunately we're probably largely attributed to our safety measures and our PPE. We aren't seeing our staff becoming infected from patient care, but rather from household contacts who are infected, coming into contact with other members of the community, just like anyone would. And I think that puts a stress on our staffing for the hospital. We have unfortunately, we do have hospital staff who are becoming infected, but also many who are quarantining because of exposures that are happening in the community. And that does put some strain on our system, but we're developing staffing plans to be able to meet those needs moving forward. So I think, the layout is a little bit different from what we've seen in the past, but we're, employing all the measures that we can to ensure that we're there to take care of all of our patients.
Great, thank you very much. Morelli, question for you on vaccines. We've received some very positive news recently regarding vaccines.
Yeah.
When will these vaccines hit the market, and how long before there's an impact on the general population?
Well, the results that we got from both the front runners on the vaccine, as you said, are very, very positive and gave a lot of hope to the rest of the manufacturers, because there are very different platforms that are being used, right? What we are focusing in the next two hurdles that the manufacturers are going to have is to secure the supply chain to make sure they can produce the quantities that they need to produce, as well as the distribution channels, right? Every country and every area, every state is working with the different different companies on different ways that they are going to source these vaccines. Also, the cold chain, we know specifically for the nucleic acid vaccines that Moderna and Pfizer are having, that have very specific requirements for the stability of the vaccine. So there are some challenges on that. But we also know that all the companies, including ourselves, we have been preparing because we always thought that this will work. So from the beginning, we were preparing to secure the manufacturing capacity. We heard a lot of deals about the manufacturing capacity. On the background, we saw a lot of contracting being done to secure the supply chain, all the raw materials that you needed to do. So I think the companies are in good position to start rolling out. I think it will depend, when we start seeing it to the public, will depend on how they balance, if they get emergency use authorization from the FDA, for example, or if they need to complete the clinical trials all the way through to start getting full approval. So between the emergency use authorization and full approval, we're going to see a different amount of vaccine being released to the market. And more than anything to the healthcare providers, most likely, and the different area and the different protocols, or the different alignments they have done with the state governments, etc., to give that vaccine to the different areas. At least publicly, the companies are expecting to have vaccine in as early as end of December. I think it's going to be probably limited amount, and it's going to be very well controlled how it is how it's distributed. By the middle of the year, I think we will see a little bit more of a wider supply. We also see at the middle of the year other phase 3 clinical trials and other companies coming out with those results. So, we have the very good news at the beginning of end of 2020. We know that we're having a lot of phase 3 clinical trials with different technologies that they may be more suitable for different populations. We will see how the side effects that generally seem to be mild. So I would say by middle of the year to towards the end of 2021, we will see a much higher increase on the availability of the vaccine. So looking forward to that as well.
I think we all are, absolutely. Very well. Katie, I see that we have some questions. So I'm going to go to the chat and see what we have. So we a question for David. It says, death rates have fallen for hospitalized COVID patients. Is this more related to a change in who's getting hospitalized, younger people, or a change in hospital treatment protocols?
So I think, that's a great question. And I think there may be elements of both at play. When we look at what's happening now with infections, at least in Connecticut, we are seeing patients coming in that have the typical risk factors. We're seeing older patients, patients with a lot of medical comorbidities. And unfortunately, those are the ones who, tend to have, not do as well. The pandemic seems to have spread much more into the community, whereas in the spring we were seeing a higher proportion of individuals coming from nursing home facilities. And those individuals, tend to be older, tend to have a poorer functional status when they come into the hospital, and their outcomes are unfortunately not as good. I think that that shift in the types of patients that we're seeing is also coupled with advances in our treatment strategies. So we have therapies that have been proven to be effective. So dexamethasone, I think, is the one medication that has the best data shown for hospitalized patients and preventing mortality, and we are using that much more frequently than we had been in the spring when that was still under study. We have some other medications in our toolkit now as well, like remdesivir, which is an antiviral drug that we now use for hospitalized patients, and that's been shown to improve outcomes as well. So I think we're looking at both aspects of those, and then on top of that, I think as healthcare providers, we've become more comfortable with taking care of patients with COVID-19 in terms of not just medications, but the overall treatment strategy. So we're doing things like different oxygenation strategies for patients that need oxygen. We have a different approach to mechanical ventilation. So early in the spring, the early data showed that mechanical ventilation early on was beneficial, but now the later data showed that that may not be the case. And that's really guiding our practice, and I think that is contributing to better outcomes. So I think it's a combination of potentially a different patient population, but also some important advances that we've made in taking care of patients with COVID-19 in the hospital.
Great, thank you very much. Mark, couple of questions for you. I'll ask one at a time so you can answer one at a time. Question is, can you speak to the amount of false positives or negatives in testing?
Sure. So for the PCR tests, both false positives and false negatives are very low. I would say more in the range of human or laboratory error than in test performance. But for the antigen tests, like the Binax Now test, it really depends on the viral load. In terms of false positives and false negatives. And I'm going to post a story from the New York Times in the chat about this that has a really good, nice summary of it. It refers to a study from UCSF that has not yet been published in a peer-reviewed journal, but is a good sort of early indication of some of the results. So for people who had very high viral load, so had low CT values, for those of you who are the PCR wonks in the audience, those were nearly as effectively identified by the antigen test. Whereas people who had lower viral load by PCR were more likely to test negative. Now, that raises a bunch of other questions around whether or not those people are infectious with lower viral load that I think we don't know the answer to, like so many other things about SARS-CoV-2 and COVID-19, where we don't know how most people get infected. We don't know how long people are infectious and in what contexts and by what routes, although we're starting to understand that much better. So I think the question is what test is appropriate for what population at what time, and the rapid tests may be really the right thing to do in a nursing home where you can test patients every day or every few days and catch those what will be symptomatic infections among people who can be pretty effectively quarantined and are not major spread risks. On the other hand, pre-surgery patients probably should have a qPCR test because the sensitivity is really quite important. You don't want to have a person coming into the hospital for surgery with any chance that they are infected, whether they're on their way up or on their way down, or will always be asymptomatic. So I think there's complexities around which test is appropriate in which context, and that they both of those strategies can be quite useful and have an important role to play in identifying individuals who may be at risk either of the disease for themselves or for others.
Great, thank you. Mark, another question for you. It was announced in the news this morning the availability of a home test kit through prescription from your doctor. Your thoughts on home test kits?
Yeah, all of the home test kits that I'm aware of are home sample collection, and then you mail in the sample to a qualified reference lab for performing the assay. And in those cases, I'm pretty much okay with that. I think the guidelines so far have been that, so there are tests where you can do self-collection of either an anterior nares swab or saliva and send that in for testing. I think those can be pretty effective. There's nothing, no offense to my medical colleagues, the spitting in a jar works fine without supervision, I think. And the nasal swabs, it's a little more tricky in terms of the depth that you go in and how many times you swirl and all of that, but the instructions for those kits are good. So I'm fine with that, and I think that those have a role to play as well.
Great, thank you. Morelli, a question for you. There hasn't been enough time to determine any long-term effects of a vaccine, and many individuals are expressing trepidation in getting the vaccine. How will this be addressed to encourage more individuals to get the vaccine?
Yeah, so when you roll a new vaccine, there is, part of the way you understand the safety and the efficacy is through very large numbers. It's more of a statistical piece. So when we look at the number of people that are getting these vaccines the first time, especially for the new technologies, you're looking at 30,000 people. Each one of those patients is going to be followed carefully to see how do they respond, how do the side effects, etc., are moving. So for the new technologies, it's going to be more about this follow-up and having all these large numbers of people that are receiving these technologies. For some of the more established technologies, there is a historical perspective on how the patients and how people respond to these vaccines in the long term. And for the most part, we know that there are not long-term effects, especially for some of the platforms where the same platform has been used for a different vaccine, and it's a very similar substrate and how you produce it and the raw materials that go into the vaccine, that we can feel comfortable that we have a large history with that technology. So it's going to depend. I think there is a very high level of monitoring. There is also a post once we start going into the general population outside of the clinical trials, there is a very strong vigilance for any side effects or any information that is coming from physicians, for doctors, and for patients. Every one of those cases is follow up to make sure that we understand what the overall impact or how the vaccination is progressing. So the infrastructure for vaccine monitoring is already in place. This is not new because of COVID. This has existed for all the companies. Every company by law has to have this monitoring and follow-up system that are very well established. So I think as we move forward, we're collecting additional data. There will be a very early signals. We are ready to detect early signals to see how it's moving forward. But in general, for vaccines, we have not seen that there is a long-term side effects, because we are using the natural immune system. We are taking advantage of our own way to protect ourselves. So we are just priming our own system. We're not adding different mechanisms of action, etc. So I think, from a safety perspective and the history of vaccines since the 1930s, I would say the danger is more on getting sick and infected that from the vaccine. That would be my outlook.
Great, thank you very much. David, you may have answered this question earlier, but there's a question here about the kind of the profile of who's being hospitalized. And the question is, are the majority of hospitalizations elderly patients?
So I think, with this epidemic or this phase of the pandemic, we're seeing a little bit different than what we saw in the spring. We're seeing some diversity in the patients who are being hospitalized. They generally tend to be older and have medical comorbidities, but we do see young individuals who are coming in and don't fit kind of the typical type of patient that we usually think are at risk for COVID-19 severe illness. So it is a mix. I think it reflects the way that the disease is spreading in the community. But those same risk factors, older age, medical comorbidities, still seem to be present in most of the patients that we are seeing hospitalized.
Great. Thank you. Morelli, another question for you regarding the distribution of the vaccine. I know you mentioned that frontline healthcare workers will probably be the first people to get the vaccine. But is there any other plan beyond that as to how the vaccine is going to be distributed and to whom?
It depends on where you're looking at, and I'll give you an example. For our vaccine, the contract for distribution is with the Operation Warp Speed. So the company is not defining how it's going to be distributing that vaccine. Is going to be developed. That distribution is being defined by the buyer, which is in this case the United States government, and we know that the United States government is discussing with the different states, for example, of how they're going to distribute that. Or the same thing is happening for the EU or Canada, etc. So depending on how the company is allocating that vaccine, whether it's, for example, Pfizer, that they're having contracts with different countries. That's how we know that the distribution is going to go. There is also, we know there are panels of groups of people in government and in communities that are making that they're looking at the ethics of the distribution and the impact, etc. So there is a lot of work going on in the field on how preparing for that distribution allocation. And it's going to vary, as I said, depending on where how it's being produced and how it's being allocated to the different healthcare providers.
I've had the opportunity to listen to General Gus Perna, who's in charge of the logistics and the supply chain and distribution for Operation Warp Speed. And it gives me great comfort to have such a competent military leader in charge. He seems to be doing a pretty amazing job in a short amount of time. So, and I think that's true for so many of you that have made such significant progress. And March seemed like 6 months, but since then it seems to have gone pretty quickly. So, so thank you. So, are there any additional questions from our audience? I do have one additional question. If a patient gets what appears to be a common cold, no fever, but a runny nose, a cough, chest congestion or anything, should they get tested for COVID-19, Dr. Bannock?
So, I think, I think we have to be extra cautious with the coming months. I think, there are some symptoms that seem to be more frequent, things like fever, coughing, but we see individuals come in with very mild symptoms, and I think that there really is a role for having a very low threshold for seeking testing. We have testing that's pretty widespread available here in Connecticut. We're very fortunate in that sense, especially relative to other states. We have a lot of access to testing, and the testing is really critical for a few purposes. Because it not only helps the individual, but it helps the community. So if we identify that an individual, even with mild symptoms, does test positive, there's real important implications with isolating that individual and performing the necessary contact tracing as well. So, my general message is, have a low threshold for getting tested. Even if it's symptoms that you think, they seem to be, pretty mild, they'll probably get better in a day or two, and they very well may. But I think there's a real benefit to getting tested, both for you and for all those around you, in order to identify whether or not you are infected and need to isolate yourself to protect others. So that's my general message. I think it's tough. Sometimes a stuffy nose will come on, and then a few hours later get better. That may be a kind of situation where monitoring would be appropriate. But I think the general message, the next couple of months, have a low threshold, get tested. And act accordingly.
Great, thank you very much. Dr. Mike, you have a question?
Yes, I've got a question perhaps for Dr. Bannock or the other speakers. with regard to viral antigenic drift or shift, number one, is that the cause for this seasonal fall surge? And number two, would the drift or shift play any role in the ultimate effectiveness of the present vaccines that are being worked on?
So that's a good question. I'm actually interested to hear how Dr. Adams, our virology expert, feels about that. But my comment is, I think we are seeing that there are some subtle changes within the strain, but the strains of SARS-CoV-2. But I really think that the increase in cases that we're seeing in the fall is not related to something that's specific to those kinds of changes, but rather the overall nature of the spread of coronaviruses. We know that in the wintertime, people are tending to flock to indoor environments, and that really does facilitate the spread compared to outdoor environments. And even the colder weather too, I think also supports the virus being stable and being transmitted. So I think that's less of the changes that we see. Some mutations that have been identified in SARS-CoV-2 explains that less than really that overall shift in behavior where activities are occurring and these sorts of things. But I'm really very interested to hear how Dr. Adams feels about that.
It's interesting that the SARS-CoV-2 virus has been the most intensively sequenced genome of any organism in history. And a lot of the groundwork was actually laid for this in terms of the flu surveillance network that the CDC set up over many years, where there's a widespread and in fact global network for sequencing new flu strains to try to design and project the flu variants that will be common in circulation and design a flu vaccine that does in fact depend very closely on which particular variants in influenza genes are the most common. So far from my understanding is that the variants that have been observed in SARS-CoV-2 do not affect the vaccine, epitopes that the vaccine recognizes, so that there aren't differences in terms of the the vaccine efficacy based on the strain. Now, in many infectious diseases, the introduction of a vaccine creates selective pressure on the virus and can lead to sort of escape variants that no longer are recognized. It'll be really interesting to see whether that happens with SARS-CoV-2 or not. My sense is from reading literature and published studies is that, first of all viruses mutate much faster than bacteria or humans or other things because of their life cycle, but also because they're kind of sloppy in their replication. And so there is the potential for that to occur. SARS-CoV-2 doesn't seem to be one of the most rapidly evolving viruses. And so that'll be interesting to see, but it's something to really keep an eye on. And the intensity of the genome sequencing that's ongoing for it should be able to get early notice of that, I think.
Okay, thank you. I had one other question, if I may. Paul, is that okay?
Go right ahead. Sure, Dr. Mike.
Okay, I hate to be a Monday morning quarterback, but in retrospect, since the retrospectoscope is always 2020, is there anything else we could have done to try to halt the progression of the COVID-19 without closing down our schools or shutting down our economy as robustly as we did in retrospect?
So I'll sort of take a little bit of the stab at the retrospectoscope and think kind of how things have gone in the past. So I think there are some factors that were out of our control. I mean, we're dealing with an incredibly infectious virus that the population is naive to, and that is in and of itself is going to create a pandemic. I think looking back to the spring, I think that the rollout of clinical testing was a challenge, and there's probably a lot of factors. Now we have such robust testing, and I know that, and I don't mean to downplay this, and this doesn't fall on our testing partners like the clinical laboratories, but I think that some of the supply chain issues that led to the testing challenges were part of it. And I think that the supply chain in general has been a challenge throughout. We look at personal protective equipment. We got by with what we could in the spring, but it was not ideal. We have been hampered by supply chain throughout. And quite frankly, we have enough PPE right now. We have the PPE that we need, but we are highly dependent on a very volatile supply chain for PPE, for testing, for a lot of what we need to do, and that is still a concern. So I think if there were opportunities to address those supply chain challenges, testing reagents, swabs were an issue, and I don't know. I'm sure Dr. Adams can elaborate a little bit on how he saw some of the supply chain issues. But I think that was something that really challenged us in the spring. I mean, we had the structures in place to address it, but I think that was something that we maybe did not anticipate to occur at the degree in which it did, the supply chain interruptions. So I think that's one aspect in which we were challenged. And then in terms of the public health measures, I sort of wish that this was a little bit more coordinated across the entire country. Each state has had their own response, and we're very fortunate that in Connecticut, our public health response has been quite robust, especially compared to other states. But I think the lack of a uniform response has not helped us in the bigger picture with being able to slow the spread. And I think those have been big challenges. But I'm interested to hear what the other speakers see from this perspective as well.
Morelli, your perspective on the retrospective scope, I guess?
Yes.
Retrospectively, I think from a vaccine development perspective, we were in good shape because we have been working and preparing for a pandemic. It was not the pandemic that we were preparing for, of course. It was a flu. So that threw the plans a little bit off because we had to start with the development piece. But at least from that point of view, I think the companies were well prepared, and we had been working with BARDA, which is the agency that is working with Operation Warp Speed, right? To the Biological Advanced Research and Development Agency for HHS. So it was fast enough. The piece that took us a little bit off guard, just as David would say, Dr. Barak was saying, was the supply chain, right? And the capacity for the production. We have been looking at capacity for influenza vaccine production, which was a little bit different than the capacity for production of these new technologies. So in retrospective, looking at the full picture from your supply chain to your production capacity, etc., could help us a little bit. But at least from a vaccine development, what has been achieved in this year, I would say it's a testament on how prepared actually the U.S. was for a pandemic, to develop a vaccine from the vaccine development perspective. To see a phase 3 clinical material going from January to July, August, when Moderna and Pfizer started, that was very unprecedented and then very exciting, right? To see that.
Thank you both.
Great, Mark, your perspective.
I agree that the speed with which the vaccine development programs have progressed is truly dramatic. And really, it shows that the investment in that infrastructure and scientific expertise has really paid off. And I think that's great. David, I wanted to clarify a number that I've seen in a couple of emails from UConn, if you happen to know. I believe that there have been, in the voluntary asymptomatic testing of healthcare workers at UConn, there have been 0 positives. Is that correct?
That is correct. So we have an asymptomatic prevalence testing that we do periodically amongst all of our staff. We offer it to all of our staff. We've had a few different ways that we've done that, but we've had 0 asymptomatic positives, and that excludes individuals who had a recent exposure. These are just we take people, say, you're welcome to test today, come get your test, and they don't have symptoms, they don't have an exposure, a specific exposure that they're aware of, and we've had 0 positives.
Yeah, and of course there have been some symptomatic healthcare workers that have tested positive, and that's an unfortunate consequence of the close care that is provided, and something of the, on the one hand, this is, I think, a testament to the power of personal protective equipment and care in a clinical context where every employee is really acutely aware of the rules and regulations and the value of doing that. So looking back, I think, Michael, to come back to your original question, what could be done without shutting down?
Yeah.
Really, this is a highly transmissible virus, and limiting exposure is probably the single most effective way to limit infections. And there was, to another comment, quite variable sensitivity to that issue across the country and in different groups and for different reasons, whether that's weddings and funerals and other personal things, or just the regular wheels of commerce, where in workplaces there was not possible to achieve that kind of distancing and protection. So that's the thing that I think is still a question of how we perceive the risk of this, and what is the risk reward ratio for trying to limit the spread at what cost over what time period. I think there's an argument to be made that more aggressive shutdowns early on might have helped, or help the long-term economic impact, but I'm not an economist. Yeah. So one of the things that I keep going back to, you might have heard of an analogy that's been getting a lot of traction, is the Swiss cheese model, where if you stack all the Swiss cheese up on a sandwich, your barbecue sauce is going to run straight through. But if you turn the slices in different ways, you create a barrier to the barbecue sauce. And I think this idea that there's not a single approach to preventing coronavirus infection or soggy bread is really true, is that it does take all of these things. It takes distancing, it takes masks, it takes testing, it's going to take a vaccine. None of these are sufficient in and of themselves. And it's that collection that's really ultimately going to lead to the decline of cases over time.
And we can see that even in vaccination, right? Because even with very established vaccines, even when we have good coverage, we can manage the disease. But as soon as you get some focus and some, lowering the amount of people vaccinated, you can still see this focus of infection, even for very old diseases that they're not as contagious, or maybe similar contagion, but you can see it even when there is a well-established vaccine and medical procedures. So that's definitely the case.
Very, very well said. Thank you very much. Well, thank you to our panelists and our audience for an informative and interesting forum today on living with COVID-19. What does the future look like? To our panelists, we're so grateful for your important work, and we thank you for your continued efforts in keeping us all safe and healthy. To keep abreast of recent developments in the coronavirus in Connecticut, I please ask you to go to the website that the state of Connecticut has set up called ct.gov/coronavirus. That is ct.gov/coronavirus. And I'm sure Katie will be sharing that information with all of our members on a regular basis. So stay safe and stay healthy. And I'd like to turn it back to Cindy Bombard, the President and CEO of the Central Connecticut Chambers of Commerce, for some closing comments. Cindy.
Well, thank you so much for moderating this morning, and for our panelists, thank you so much for your time. We know how busy each one of you are, and for all of those that attended, again, thank you for being a chamber member and supporting us in everything that you do. And for Connecticut, you're a great partner to the Central Connecticut Chambers of Commerce, and we are thankful for that as well. So wear your mask, sanitize, wash your hands, be well, stay well, enjoy your Thanksgiving with your holidays, upcoming holidays, and we shall connect soon. And Lisa, thank you so much for helping us coordinate. Greatly appreciated. So everybody enjoy the rest of your day.
Thank you very much.
Thank you. Bye.
Thank you. Bye, everyone.
Bye-bye.
God bless you.
Thanks.